Well, welcome everybody. This is Kevin Croce from Boston. We're excited to do cases over cocktails. Thanks to the UW team for giving us their Zoom portal to host. It's been fun to get together with everybody from across the nation that are interested in this space, especially our many CHIP fellows. So for tonight, we're going to talk about something that I'm excited about, Imaging and Physiology Part 1. We've got Katie Dawson from UW and Pratik from Emory, two well-known CHIP fellows, and they've got 4 cases to share. I think we're going to alternate, and Pratik, you're going to kick it off, right?
Yeah, sounds great. Let me share my screen here. All right, can you guys see my screen?
Yep, looks great.
All right, great. So I'm actually going to start with my second case first, since Bill and Stefan are on. Let's see. All right, so it's a 78-year-old male. He presented to Emory University with exertional angina and dyspnea. He has a history of attempted PCI of the LED in 1984 by Grunzig, and that was unsuccessful. And at that time, he was offered cabbage, but he declined. Somehow was put on warfarin therapy for 36 years. And then he read about some new contemporary PCI techniques and decided to get further evaluation given his symptoms. And notable laboratory findings at normal renal function, creatinine of 1.2, and echocardiogram showed an EF of 40%, some inferior hypokinesis. So here's his diagnostic angiography here. I'll kind of let that play for a couple of cycles here. And you can see he has a significant circumflex obtuse marginal disease. OM2 is a bifurcating branch with an occlusion of the lower branch. There's a LAD, prox LAD CTO as well. And then angiography of the right here shows some significant calcified proximal RCA disease. And you can see the septal and epicardial collaterals to the LAD. And then a ventriculogram here on the right with EF of 45%. And so I'll just pause here and see if you know folks have any comments or thoughts on the anatomy and what their thoughts would be in terms of how to proceed with thinking about revascularization in this case.
There's a lot to do there.
It's a target-rich environment, as Dr. Lombardi would say.
How old is he, Pratik?
He's 78.
Great. So sending a 78-year-old for cabbage is probably not fun or the right thing for him. Viability study done?
So you know his echo was essentially there's intact wall motion, mostly just with inferior hypokinesis. So he did not get a viability study.
Yeah, I think that's fine. I mean, I look at echoes that way. If all walls are moving at least a little and all walls are thick, I think the viability study wouldn't offer much in this scenario. That's great.
So, all right. So, I mean, here's what, so we were thinking, obviously he's got multivessel disease. He has typical, class 3 symptoms. And so in a situation like this with multivessel disease, complex anatomy, we have the syntax scores and STS score for risk assessment, which can help guide decision on revascularization with either cabbage or PCI. And obviously, shared decision making is an important part of the process with the patient and their preferences. And so for this gentleman here, I calculated his syntax score to be 36.5. So this is lesion 1's RCA, the LAD CTO, he gets 20 points, and then the 2 obtuse marginals, and then the distal circ here. And then, you can incorporate the syntax score with other clinical variables for the more contemporary syntax 2 score. And so inputting the variables here with the syntax 1 score, his age, renal function, ejection fraction. He has no left main disease, gender, COPD, and peripheral vascular disease. It gives you kind of a recommendation on optimal kind of revascularization strategy, so to speak. And for this gentleman, I guess the recommendation based on his clinical variables and the syntax score and the anatomy was for CABG. And his STS, the risk score, actually, if you look at the risk of mortality, it's about 1.2%. So it's not too high. And any comments or thoughts on that, Kevin, or anyone else on the panel?
Yeah, I mean, risk of mortality is fine, but, return to functionality, protracted rehab, and does it get back to the quality of life you had before this after CABG is always something that, syntax scores and STS scores don't really capture. And I think that's a little bit where there is some art to this. I mean, odds are to get through the CABG safely, but, in a center like yours, he's going to get a pretty good revasc and get home a lot sooner and not be laid up for a period of time. And so you had shared decision-making as one of the things in your assessment. And so I think, a heart team discussion and a conversation with the patient about what it entails to go through bypass and what it would entail to go through a reasonable approach, getting good revasc, hopefully complete by PCI is something which is certainly in play here.
Yeah, great points. And, that's one of the things with his age being 78, the rehab component is huge, obviously. And talking to this gentleman, I mean, that was one of the things that, he was very active. He did not want to, that rehab component was a big issue for him, so to speak. And so, he declined CABG and opted for multi-vessel PCI. And so obviously our plan was to try and offer him complete revascularization, which would mean intervention on the CIRC OM, the RCA, and the LAD CTO, which, looking at it, I think probably classified it as a JCTO3 based on the long occlusion. It's calcified, and if you consider the prior attempt as one of the points. So I guess intervention.
When Grunzig was a previous attempt, I think we should get 2 points for that.
Yeah, I was going to say.
Absolutely.
You're lucky Gerald is not on the panel, because he would probably say that it's a JCTO 0 here.
Yeah, I mean,
we would welcome the transfer him to Germany for them to do it. So.
I agree.
So here's his anatomy again. Any, I guess, comments, thoughts on how to approach this?
What do you think, Katie?
I mean, how we or how I've experienced this generally approaching cases like these is you kind of have two options. Do the thing that you think is going to be hardest first, or do the things that you think are going to be easier first to improve perfusion to the bulk of the myocardium before you tackle the harder thing. I think that, did you guys talk about whether you would do it as a multiple procedures as a staged intervention, or whether you would try to tackle everything up front?
Yeah, that's a good point. I mean, I think, that's something we always talk about is what do you do the hardest thing first, or you get the easy, quote unquote easy.
Yeah,
or
easy being a relative term,
yeah, exactly, out of the way first. And so, I mean, I think, probably our approach was to try and do everything at the same time. Obviously, depending on how it went with each strategy or each lesion, but going in, I mean, our plan was to do everything kind of all time.
It'd be good for Stefan or Kevin to comment on, do you guys It's funny because if you talk to some of the senior people that have been doing this for years, like John Douglas, I mean, he's more of a fan of going after the CTO, thinking that, if there's a chance you get it, that maybe gain some advantage. I think it's become so predictable sometimes with some of these ones that look tough, like the Circ, that we all know that do a lot of complex PCI. It's not really that hard. I'm a big fan of capturing territory that you're going to have to your advantage when you take on the more complex case, which is obviously the LAD, because that's where we run into our complications. And so like I would like to have more perfused myocardium that I know I can capture with little risk first before tackling something I know that could result in perforations, tamponade, and dissections, and loss of flow to territories that are used to getting flow to some degree at least. And I don't know, I'd be curious what Stefan and Kevin, two very experienced operators, would say about that strategy.
I tend to take your approach, Bill. I mean, a little bit of it is predicated on how scary the CTO is in terms of whether there's it's a high risk, high complication CTO, like a difficult retrograde or something. But, I believe also patients are more likely to tolerate misadventure if at least the one territory we can get in with a couple stents that are not a CTO are secured, especially if it's collateralizing other territories. And so, if you have some disaster in that LAD, it'd be tough because then really nothing's working, at least this way the circumflex and the two big OMs are intact and in place. And so I've tended to lean your way where you chip off the stuff which is straightforward and then move on to the harder things. But other people say, all right, effectively, if you have some disaster for an unexpected reason in that circ and bifurcating OM thing, then you've got nothing to protect you. But I think that's a pretty, you're looking at a pretty predictable OM angioplasty for both of those. It's bifurcation, it's hard, there's a CTO in the middle, but I mean, that should behave okay, would be my sense. Stefan, what do you think?
I'll get a very boring answer. That is, it depends. It depends on the situation. I usually teach the fellow to go with the flow, because if you have a TME2 flow, if you have TME3 flow, otherwise in donor arteries or something, it's not by fixing these arteries that you gotta make your procedure safer on the CTO. However, as you can see on the circ, the inferior branch of that OM's got slow flow, and therefore opening this prior to the CTO might be a good advantage. The other situation where I would consider doing this before the CTO is when I may instrument the donor artery, obviously. So therefore you have to treat the donor first. However, let's say all the lesions there would be relatively simple, and you would only have an integrate CTO PCI on an LED that's relatively a straight shot. You might as well just start with that and finish up with your non-LED CTO, non-CTO lesions. But again, and it also depends on the artery, right? Because I think here, given the LED, all the options of the LED, including some of the retrograde options we have on that LED, and the fact that an LED single robotic option is certainly not a bad option. Treating everything else, even if you fail the LED, you'll be able to get it done and revascularize whatever the situation is. However, if it's the RCA, let's say, you might not be able to revascularize, and then if the patient is a 3-vessel disease, therefore considering the open option of bypass is certainly something that you have to consider. So it's difficult to sort of get a rule, but you have to sort of weight your chances of being able to do a complete revascularization percutaneously and not removing the option of of a more complete revascularization surgically if the patient is a candidate. So long story, it's a bit boring, but I guess it's how I would think and analyze those complex cases.
You know, I think Stefan, like, you know, like it or not, you and I have become two of the older people in this field, but you bring up a very valid point about the donor vessel, and I learned this from you back in 2010. I mean, you had a case of a retrograde right that you were doing with a moderate lesion in the LAD, and had that LAD shut down on you, and had to do some maneuvers that you're gifted enough to pull off to get yourself out of the fire you got into. But I think it's incredibly important to emphasize that if you're going to use a donor vessel with disease, you're smart to treat that up front. And I think that that's really valuable information for people to think about, like, where are you going to be passing through your retrograde catheters, even if it's a moderate lesion, if you're going to be roughing that up on your way through to go to a right, or vice versa, moderate lesion in the right that you're going to go to the LAD. It makes a lot of sense to treat that up front. And I think, you know, for some of the younger people on this panel too, or on the call too, you know, what Kevin and Stefan, what about that middle branch that's coming off? You know, we're focused on the big branch going south and the big branch going, you know, east, but there's a little branch in between. Are you going to get hung up on that? Is that going to, I mean, is that your complete revascularization? Do you have to spend a bunch of your time perseverating on that, or is that just collateral damage?
Well, personally, I think it's an underperfused branch and might grow quite significantly. And second is I would be worried about, because there's not much collateral going there. There are, but they're not. So if you just treat it with neglect and just do the AV groove circ towards OM2 and then don't treat that lower branch, you may lead to a complete occlusion and the patient remaining symptomatic or something. So I don't know. Personally, I would give some time to open this up as much as the other branches, but again, that would,
would you balloon it, or would you stent it and then do a trifurcation-ish kind of case?
no, Bill, that's a good point. I mean, look, if we look in terms of architecture of that, you're probably able in this case to avoid, you know, touching too much with stents, right? The branch is lower. Unfortunately, in the US, we don't yet have drug-eluting balloon, because this could be a very good option.
Yeah, it's
to
such a
treat.
disadvantage. You're so right there. Like, I mean, for me, looking at that, like, I mean, you've got, if you think about like where you're really going to have a wall motion abnormality, I mean, if you open up the top of the branch and the bottom of the branch and leave that little middle one, can you really like fathom how that would affect the wall function of that portion of the heart? I don't know. Like, I think if you had drug coated balloons, like you're alluding to, like it's a different game, but I can't imagine putting a third stent there. So
No, and you're right. It's all a question of how, you know, if I would certainly try to provide a TME3 flow in there and balloon the branch, and maybe you use a 2-stent strategy. But again, you're right. You don't want to embark into a very complex 3-stent strategy that may not yield the same longer term outcome as a much simpler approach. However, I think there are ways to be creative with that bifurcation and get good results with 2 stents, with that trifurcation, I mean, and get good results with 2 stents.
Hey, Bill, I'd probably cross it, balloon it, see how big it was. I mean, I'd consider 2 little mini crushes and a stent into the upper pole and just a quick recross and squeeze them. Not a DK, like doing 2 DKs would be a pain in the ass, but the angles are favorable for, you know, a couple struts across and then just paving across both, and at least considering rescuing it. But seeing if it grew after crossing, ballooning, and nitro, I think I'd make a game time decision. But Much to your point, it looks pretty straightforward. I try to pop it open. These circumflex OMs often get huge after you perfuse them.
Yeah, for better or worse, I don't want to spend too much time and we're talking about a bunch of more interesting stuff, but I mean, for better or worse, like to me, it's a little fat right after the occlusion, but it's really a vessel to nowhere. And so I've become very good at having tunnel vision and ignoring that. And so I think you could do a nice mini crush little T stent on the 2 branches that matter and move on to the meat. So, but go ahead, Pratik, go ahead and start moving forward.
All right, so we started with the circumflex, and so we wired both IVUS, and based on the IVUS stent sizing, essentially did sort of like a T stent. We did a 2.5/30 down in this AV groove circ, and then a 3.022 in the OM there, and we ignored that other branch right there that's off the bifurcating OM2 essentially. I did this case with Bill, so he's kind of aware of that.
7 French femoral, Bill?
Yeah, so here, our plan was to do the CTO as well. So we started out, we had radial femoral access. We did this through the 7 French femoral EBU 375.
Okay.
It's a nice result here. And then we moved on to the RCA. You see there's a calcified disease here in the proximal segment. I have the IVUS here. You can see, I'm gonna let it play here, but there's 360 calcium in that segment, and which we felt like would need modification with so we proceeded with atherectomy. Any comments on the IVUS here, Kevin, or I'll let it run.
Yeah, no, I agree. Arc at 300 or more looks like a pretty long length of it. So
yeah,
people are developing IVUS guided scoring systems that predict pore stent expansion. You've got 2 or 3 of the markers of it. So that didn't look like something to me that would respond too well to an NC balloon. It looks like it's going to need some advanced vessel prep.
Kevin, Kevin, you're as good as anybody in the world on imaging. Tell me, so do you change your burr size by the reference vessel size? Do you go 1.5 with everybody? Do you do 1.5, try to expand, and then go 1.75? I mean, what's your algorithm for this if you're not doing OCT with depth of calcium and so forth?
That's the reason why I prefer OCT, Bill, is because if you can see how thick it is, I'm starting to at least get it, my own personal experience of in a proximal vessel of a certain size, as the calcium gets to be more than 1 millimeter thick, at least in my experience, a 1.5 burr doesn't do anything in terms of getting good stent expansion. So, I'm either going 1.5 and then a 1.75 when I see that scenario. Orbital works well. I'm pretty liberal with using orbital on high speed, although I know some people are pretty anxious about it. We actually did 2 cases today and one on Monday where we did a hybrid, orbital tripsy and then a rototripsy. And it's amazing in a big proximal vessel. These 3 cases were all OCT guided, but when you put a 1.5 roto burr through, I can show you 2 cases from this week where there was still 1 millimeter of calcium 360 degrees around it. And so that's why in these big vessels, a 1.5 burr fails. And I think what you may be alluding to is I'm pretty comfortable going 1.75 just right off the bat in big vessels that have that much burden, because a 1.5 often doesn't get it done. The time when it does is if you get a lot of wire bias and it kind of grinds out the calcium to the intima in one part of it, but that's a little hard to predict. The right may be better for that because you get more wire bias, but the time it usually fails is in the LED where the bird just kind of goes straight and it leaves a nice tube with 360 degrees of calcium around it still. So I tend to be a little bit expediency minded, where if the imaging says it's going to need, Gestalt-wise says it's going to need kind of 2 burrs, I just sort of go with it up front as opposed to switching wires out and playing a multiple swap out game. But what do you and Stefan think?
Well, I was curious. I mean, there's a couple of questions on the chat, like why IVUS instead of OCT? Like, tell me your thoughts on that. Like, I mean, there's nobody that knows more than you. So, and I'm curious, like when you add to that, I mean, this is like just begging for IVL, right? I mean,
yeah. So when Pratik spent, I was pestering Pratik about this when he was up with us for a couple of days, but the thickness really helps to understand how thick it is. And, you can see nodules better by OCT. And so for us, even antegrade wire escalation CTOs, once it's ballooned, it's just a type A lesion most of the time. So we use OCT in all those too. And so we're probably 60 or 70 OCT to IVUS. And it's mostly because, I'm not smart enough to read IVUS. And so the OCT is like paint by numbers. You can measure stuff better, thickness, length really well, and then you can plan the case really easily. But, it may just be a crutch, but I think that thickness information is super helpful. But
Although
there's reasonable metrics of IVUS, based on vessel size, arc of calcium, and length. On the scoring system, Viad and friends are trying to get published. If it hasn't come out already, there is a good prediction of whether or not you need 80% stent expansion too. So it's a little bit harder to apply just because the granularity of thickness isn't there, but the scoring system is pretty similar otherwise.
Well, for the fellows on the call, why don't you go through that real quick for what, like length of lesion, thickness of calcium?
Yeah, so the length consistently between IVUS and OCT, which seems to be pretty noxious, is 5 millimeters. And then an arc of greater than 180. And certainly if it's more than 270, and then smaller arteries, at least by IVUS, tend to have a little bit more of a prone, especially with a lot of thickness of intimal calcium and needing advanced vessel prep to get your stent greater than 20 millimeters, then greater than 80% expanded. For the OCT piece of it, I don't know if you have that slide in your deck, Pratik, but for OCT, it's something called the calcium volume index. We talk about the rule of fives. If the arc of calcium is greater than 180, you get a point. If it's greater than 270, you get a point. If it's 5 millimeters long, and if it's half a millimeter thick, you get a point for each of those. Over 3 points, you start to have your stent expansion drop off precipitously. And I'll put a picture of those things on Twitter tonight if anybody's interested in it, just so you have a rule of thumb. But it's cool. We do a lot of complex PCI that's image guided in our lab, and we routinely, especially in July and August, I'll pester the fellows to look at the IVUS or look at the OCT and justify why atherectomy either is or is not needed for a case. And so these papers that have come out, in the past couple of years are helpful because, Bill, when you go to try to teach people complex PCI, one of the hardest things to do is to get 10 experts in the room to agree upon what the vessel prep strategy should be, and sometimes even whether it needs atherectomy. And so having a little bit of guardrails, at least in terms of when the imaging will predict crappy stent expansion, has been helpful to me because then I can have an informed discussion with trainees and colleagues about how to run a case based on that based on the imaging that you see.
I think that's very well said. I'm curious, you brought up the calcium nodule. So tell me how you approach that. This isn't that, but that's one of the real controversial things. Do you go rotoburn, shave it off in an IVL? Do you do IVL up front? And a lot of people think it doesn't have the same effect that you'd like to have. How are you approaching calcium nodules?
So I'd always favored orbital. It depends a little bit where the nodule is. These things often occur in the ostium of the circumflex where stents tend to fail. I think because there's a lot of calcium there and people are often afraid to apply mechanical atherectomy there. But, if you're going to touch these with a nodule, you've either got to have your wire bias go toward the direction of the nodule. Sometimes you can't control that. And even with IVUS, sometimes you can't tell what side it's on. But one of the nice things, at least mechanistically with orbital, it has the potential to be more advantageous because, as it circulates around, it's maybe touching the nodule for some part of its orbit. And so when I see nasty nodules, I tend to orbital. There's been talk about the fact that IVL doesn't work, but we've had, in-stent neoatherosclerosis and some sort of nodular and then non-nodular calcium where in some circumstances it's had a good effect. I've struggled with predicting when IVL that I'm often using for a different reason, much like the lesion you show here on this IVUS, but it's actually, it's been able to modify that too. It's probably not its sweet spot, but it's not to say it's never effective there. But if I see, purely nodular calcium, I'm tending to think that it's an orbital case, especially in big proximal segments. You can hit it well with roto, but if you have a small burr and the wire bias is not in your favor, then you're going to potentially have a scenario where you don't touch it much, depending upon how the burr tracks over it. And so for me, I guess by way of summary, it's usually an orbital problem because at least mechanistically it seems to make sense to use it there.
So I'm going to eat up too much time, but I want to ask you two questions with that. So for us, IVL in nodular calcium, if you were willing to spend all 80 pulses on the same spot, I think it does work. Okay. So, so explain to me how you mitigate your risk of perforation with orbital, or I'm sorry, rotational. What do you do in those cases to minimize your chance of perforation? And
I guess
in mind, so everybody should know, like, the perforation rate for orbital atherectomy is around 1.8, 1.9%. And you get into some of these cases where if you're going to go at high speeds and you're, going to do things with orbital rotational, you're going to end up with a little bit higher risk. So I'm curious, like, how you've kind of reconciled that in your practice.
Yeah. So, first of all, I think the technique with orbital is essential. And, we had our chip fellows from Canada. He hadn't used it much. And then we did a case today where I hovered over him because of the mistake people make is taking their roto skill set and applying it to orbital. And when you push on the device, if you don't notice it, it stops and you keep pushing. And the burr is a little hard to see. So you got to be kind of mindful where it is. But it's when you push, the thing spring loads and then jumps through that it perforates and tends to get in trouble. So you need to just sort of unlearn your roto skill and apply it and learn different, and I think very discrete orbital skills. In scenarios where there's tortuosity or even like on the bend of this right, many would advocate for glide assisting past and then orbitaling back. That's certainly reasonable. I'm pretty comfortable going in the forward direction, just not going too fast and not letting it jump and all the stuff we talked about to keep it from jumping. And then I think avoiding severe tortuosity with orbital is least spoken about. I mean, I've applied orbital to many tortuous cases and knock wood, haven't got burned yet. I actually look at this conversely, Bill. I mean, calcific nodules tend to make your stents look terrible. People then see a hazy looking stent, they image it. The stent is shaped like a heart because it's got a divot in it. And they take a 1-to-1 size NC balloon really high to try and make themselves feel better about the stent looks terrible. And they push the calcific nodule through and perforate. So in my mind, mechanical debulking for calcific nodules is way safer. And so, be it your comfort with roto or orbital, we use orbital a lot at our place, have a very good experience with it, and are just mindful of the fact that you need to use it a little bit differently than rotational. But by way of summary, go slow, don't let it jump. And if you're worried about it, orbital backwards are sort of the major teachings about this. And then only apply the high speed one in large vessels and straight segments is sort of the other summary, I would say.
Kevin, it's very thoughtful. I'm gonna sound like the oldest doctor here, and I think it is what it is. I have to accept that I'm becoming older. One way to make a good work is also to bring your NC balloon on that lesion to inflate it and see how it behaves. Because if your balloon expands very nicely and you've got absolutely zero doubt about it, I'm not worried about stenting afterward. Now we've made it a bit more complicated with IVUSing and OCT before and everything. But it used to be that you would bring a balloon, and if you're not satisfied on how the balloon behaves, you would escalate, you would bring your rota, you would bring your thing. But now we're trying to predict what a balloon used to tell us, how the segment was doing before going with fancier ways to analyze it. So I just want to just be a bit of the naysayer, old fart.
No, I appreciate that. But the problem here, Stefan, is that the old school practice, I'm going to take my 1-to-1 size predilation balloon, look how it behaves, put my stent in, and then the stent looks good angiographically. Like, I have no problem, even internally, I'm like the most self-critical person. Like, I'm going to decide not to atherectomize this lesion. I'm going to take a 1-to-1 size balloon, I'm going to blow it up, put my stent in. But now I check on the back end, and I'll tell you with certainty whether I get it wrong or right based on the fact that we get intravascular imaging. So the old guy era of I 1-to-1'd it, half the time you're getting the 1-to-1 sizing, at least a quarter size or half size wrong. And you're putting a stent in and you're relying on the angiogram to let you know how the stent looks. And we know that's fool's gold because you really can't tell whether it expanded well. And so if you're making those calls and imaging on the back end, then you're keeping yourself honest. If you're just looking based on the angiogram looks okay, like, you put your thumb up, you really don't know, because the deformation and stuff you see on nodules, you won't see well by angiography alone. And so, you know, in cases where I decide to be parsimonious with prep, I know if I made the right decision. And sometimes I lick my wounds and say, geez, you suck. You got this really wrong. You need to do better next time. And that's where I'm trying to learn how to apply these tools in a way which is both efficient and helps me to get a better job done for patients.
Great points and great discussion on that. So just kind of moving forward. So you see we concentric calcium, our distal reference was 4 millimeters, proximal was 5.0. We did use a 1 fiber just to kind of shave off the calcium, 180,000 RPM, and put a 426 stent and then post dilated to a 4.5 and a 5.0 proximally. And great result here on IVUS. I'll let it play here for a second. Distal stent edge looks great. It's well expanded. So that was the RCA, and then we moved on to the LAD CTO, and so you know we have a radial femoral access, and so one of our guide choices for the RCA we really like is this 3D right guide from the wrist. Works really well. Basically, it kind of comes in pointing at the left main. So I'll kind of show how we engage it. But points at the left main, you counterclock it to unwind, and now it's facing their RCA, and then you basically clock it in to engage the right. And it's really great backup, easy to manipulate. You counter to disengage and then clock it to engage the coronary. And so this is pretty much our go-to guide from the wrist now for RCA interventions. And this is a 7 French.
Pratik.
Yeah.
Can you go back to that video?
Yep.
Thank you. We just ordered these. I haven't put one in the body yet, so this is super helpful. Cheers.
Yeah, absolutely. So yeah, basically, so you'll see it come down, pointed to the left main, you counterclock it, and then here it's pointing to the RCA, you clock it in to engage, and it's really a great guide from the wrist here.
Using that for my preferential guide for the right. It's like when I have the opportunity to go from the leg with an AL or from the wrist with this, I prefer this. And I've been doing it for about 5 years, and it's a great guide. Medtronic's the only one that makes it. You need to get it, and you need to learn how to use it.
Yeah, I've never used this one. We usually use an AL for the RCA, kind of regardless of whether from the wrist or from the leg.
It's a fantastic
So,
guide. It's a little tough to learn how to engage it, but
Yeah.
what you right here is how you do it. And you'll see when you uncoil it, you can't uncoil it too much or it flips the whole way around. But right to there, and it'll drop. It'll drop about maybe a centimeter, and you just clock it in. And it's wonderful because you can deep engage it. I can't say deep throat apparently anymore, but you can deep engage it. And then you can counterclock it to put it at the ostium. It's a great guide.
Great.
All right. So this was our setup for the CTO dual injections here. I'll let this play. So we have an EBU 375 from the leg in the left, and then a 3D right 7 French from the wrist. And you know, so you can see the proximal cap of the CTO in the LED here. It's tapered, and there's a beak, and the occlusion segment is about 20 millimeters. It is calcified. There's good collaterals from the RCA, septal and epicardial. And so at this point, I guess Stefan, Bill, or Kevin, whoever, how, you know, what's your thought process as you approach this from a CTO intervention standpoint?
I would just do whatever Grunzig did.
Yeah. With the fixed wire balloon.
No, I think it's a very, I mean, there's not much ambiguity in the proximal cap.
Mhm.
There's a very good landing zone, and there's nice septal collateral. So therefore, it'd be the perfect life case to select. You have
right.
like all 3 options you
Okay.
can do. You know that if you master ADR, retrograde and antegrade wiring skills, that the likelihood to open that vessel is quite high.
I think the epicardial is out of bounds. I mean, I don't think you can go through that epicardial. I mean, it's
the two conal, there's an RV branch and then there's a conal branch. I think these are pretty bad. However, there are a few septals coming from the that seems to be reaching from the mid. I'm more referring about.
Yeah.
I'm referring to these ones, not the epicardial build, but I agree with you.
The septal, for people listening, you're absolutely right, Stefan. You always are. But I mean, the septal comes in right at the distal cap, which can be kind of challenging to do. To me, this is like a perfect example why everybody listening that wants to do complex PCI. I always say this, like, you can't just play with a 7-iron. You need the whole bag of clubs. You have to be facile at dissection reentry, ADR with Stingray or whatever future devices are available. For my own plug, but I think you have to be able to do this. I think for you to do this case safely and reliably, you have to become really good at ADR.
Yeah, I mean, that even if you get retrograde in that septal, it's going to be an exercise in misery getting any purchase to go. I mean, I would start to say, Bill and Stefan, that's pretty much an unusable angle. Don't you agree?
It's a very hard retrograde case, and to Stefan's point, we did do this case live in front of a couple of thousand people. So, you know, maybe not good judgment, but it is.
So I think, you know, although we say that, you know, settle right at distal cap, they're less likely to be usable. They're not that difficult. It's not that difficult, especially on an LED, to flip the wire back into the body of the CTO, even if they look.
What do you use then, Stefan? So you're going to need a sharp wire to penetrate the distal cap. So do you?
You know, not. I don't think so, Bill.
And just
no, Bill. I think at this point I would just, if let's say I'm going retrograde and it works, and I'm totally with you. I would, this case is an antegrade wiring plus or minus ADR. But let's say you fail with these two strategies and you want to go retrograde, I would use the same approaches. I would probably just keep my microcatheter in that big trunk of septal and try to get a Mongo wire to wire towards the segment, and it will likely penetrate. As we know, the distal cap of this LED is filled with collateral. It's likely softer and probably relatively easy to engage. It's not like a post-cabbage a calcified cap. It's a native, and I wouldn't be. I think it would be relatively easy to engage despite the angle. But that being said, as you pointed out very accurately, is that if you know how to perform an ADR, and you're this case has a great likelihood to be successful this way.
One of the great things about getting a chance to be here at Emory with you and with some, like probably two of the best CTO operators I've ever worked with, is to ask you questions that I actually really want the answer to. So if you came all the way retrograde with your microcatheter and you couldn't penetrate that cap with a Mongo or a Pilot 200 or like a medium weight jacketed wire, would you be comfortable sitting there at the septal and poking at the distal cap with the Confianza? Like, is that, I don't know.
No.
Like, right answer.
No, I would not. I would not escalate any further than Gaia or something. I would not go to a Confianza. But I think, you know, I don't recall a situation on an LED native, not calcified, where I had to poke with a hard wire when I came retrograde. It's very unusual. If you think about it, it's most of the time you'll be able to penetrate with the polymeric jacketed wire and get your way somewhere. I mean, you'll get sub in the mold and then you'll start your dissection, but it's not.
It's invaluable. It's invaluable information you're giving. I mean, you got 3,000, I would think, CTOs under your belt to say that. And that means a lot to me to hear you say that. I've had situations where I worry about what you're describing, but let's not eat it up too much. For 40 minutes into this and we're on one case. So let's go ahead and Pratik finish it.
Yeah, all right. So, as we mentioned, we started to integrate. We started with Turnpike Spiral and Mongo. We were able to engage the cap, but due to the calcification, had to escalate to Gaia third. And here you could see we are subintimal or extra plaque, I should say. And at this point, the options are, I guess you could try and parallel wire, or you could move to a Stingray reentry. And not sure if anyone has any strong feelings about parallel wiring, or would give that a shot here. Stefan.
Oh, I think at this point,
Stefan, you live in the US, you can't say parallel.
no, and I've not done parallel wire for so it's
For 6 months.
no, I mean more than this. The reality is that nowadays with the recross coming up in the US, and I'd see a message from Stefan Harb on the chat box, and actually the recross can be extremely helpful in these situations. However, you have to think that if you're out to be doing that strategy, is that you don't want to wreck the reentry zone, and you don't want to propagate the reentry zone to be more and more distal. So in that situation here, where you have like a wire that's perfectly sitting next to the lumen, in like undoubtedly into the vessel structure, your next best approach is likely to bring a Stingray and perform a very dedicated pinpoint reentry where between the first septal and where the epicardial is entering into the vessel, and that's clearly the approach that I would have selected.
All right, so that's exactly what we did here. We exchanged out for Miracle 12, and then you can see our Stingray balloon here, and just an angiogram here to see that we have the stick left on the screen, or right, my right on the screen here towards this side from the Stingray balloon. So next we took an Astado 20, and here's the stick. I have another run here, so you can see the Astado 20. We just did a stick and drive, and then on the right here, you could see with the injection, we're in the true lumen. We repositioned from the branch here, advanced our microcatheter, and exchanged out for a workhorse wire at this point. And here's the IVUS of the LAD. And to be perfectly honest, these are some of the most challenging kind of IVUS runs to interpret. It's just so much disease and remodeling, and also your intraplaque, extra plaque throughout. So, but essentially, we sized our distal vessel to a 3.0 and a proximal to a 3.5. I'll kind of run this slow, but any comments on the IVUS here, Kevin?
I think it's helpful for sizing, and it's always fun to see how long you were extra plaque for, and so it gives you a sense of where you entered and came back. And it looked like the amount of subintimal tracking you did was limited, and so you preserve septals, which is really nice. So there's and it's kind of always looking to see, is there anything noxious from a stent expansion standpoint that would require at least atherectomy in the proximal segment. It looks like it's 180 most of the way, so you probably get away with balloons. Just make sure they're 1-to-1 size when you put them up.
Yeah, exactly. So that's what our thought was. It wasn't really. It was mostly 180-degree calcium. So we just pre-dilated, and then here's IVUS extending back to the left main, essentially. And we felt like we had the stent all the way back to the left main. So We'd probably take another stent, basically 3.5, and then a 5.0 in the left main proximally based on the IVUS here.
We had a case like this a couple of weeks ago where we had, gone subminimal or re-entered, and there was still a lot of calcium proximal that wasn't releasing well. It's a really nice reason to use IVL because, you don't have to do all the stuff we've done before in terms of, rotoing and subminimal planes. And I think that, at least up to the point where you have to pull wires and play with roto wires and you've gotten across the CTO. And so it's a nice part of that is defining it. And if the proximal segment looks like it's a little bit noxious from a release standpoint, lithotripsy is really a good tool here. It's just simpler and faster.
Yeah, absolutely. We didn't have access to that at this point, but that's a great point. It's just a lot more kind of quick and less exchanges, etc. So definitely more convenient. So we placed a 3.038 here, and then a 3.5 38, and then post dilated to a 5.0 in the left main.
I think, Kevin, we have also to keep in mind when we're discussing about stent expansion and residual, optimization, all the rules have been derived for non-CTO lesion and mostly if it's CTO, it would be an intraplaque stent delivery. Because in terms of eccentricity, malapposition, if you're stenting extra plaque, you have to bite the bullet.
Yep.
And there's no way you'll be able to turn, to put a round shape into a moon shape structure. It's just impossible. So
yeah, and there's a hazard to doing dumb stuff to make it perfect. Completely agree.
And your MLA really doesn't get affected on restenosis by shape. I mean, it's your MLA, and so you're achieving it here. I'm curious. I'd like to really ask, when it comes to this, Stefan, how do you size your stents? I mean, these are negatively remodeled vessels distally. So like when you IVUS that and it's a 2.5 distally, but in your heart of heart, it's 3.0.
Mm-hmm.
How do you choose your stent size? How do you post dilate? Do you leave a Bill Lombardi and is a big fan of, from my understanding, of kind of sizing it 1-to-1 what the IVUS shows and then leaving that distal strut or two to fit the vessel the way it looks now, and then sizing the rest of it to fit the way he thinks it's going to look later. What do you guys do with it? How do you reconcile the negative remodeling for your stent sizing, and how do you post dilate?
I do the same sort of thing, gut check on what it should be for an LED that's, this size and caliber, knowing that the negative remodeling is going to be a lot smaller than, it should grow to someday, or at least at what it started at. And we do the same thing. We take a stent that's as big as possible without dissecting the distal edge and crank up the post dilation balloon 4 millimeters back from the edge and just sort of let it taper down like a cone. Because if you start going crazy there, then you end up extending stent, which isn't good for the patient either. And the guys in Europe talk about bringing people back for optimization later. That's hard to make practical, but there is a lot of conversation about this. There's also some IVUS features that can help you. I mean, you can't tell the difference between diffuse disease. If it's a normal looking artery structure, but it's just small, it's negatively remodeled. If there's a ton of plaque, then you know that it's a different entity. The latter of which is more miserable to deal with. And even in the past month, we've had a bunch of those. Sort of open it and the target's terrible, and you spend 3 hours or something that looks awful, and it's probably going to look awful forever. But and then in the proximal segment, the thing about, to Stefan's point, to look at percent expansion, you need to have a reference segment, right? You don't have a reference segment here. So this is where I think it's nice, because all the AI algorithms for imaging, there still will be value to people like us, because you got to figure it out based on either experience or a little bit of what the rest of the architecture tells you.
So Kevin, would you be able to OCT the LED? I guess I guess the outflow is pretty good with ballooning. Would you OCT that, or you would? IVUS?
Yeah, I mean, I tend to be a little cost minded too. If I pulled an IVUS because I had, animal tracking and was worried about blasting a bunch of contrast down there, I'll usually use an IVUS on the back end. But for type A CTOs that we've crossed, true to true, we will routinely do OCT after we balloon them, because a lot of times in case you get a balloon to get imaging catheters down there also. But with this particular example, the distal vessel looks pretty shoddy. So, finding some reference, it tapers nicely. The mid and prox segment look like they're pretty well expanded. There's a couple little dimples in it, but I think considering what we started with, this is not an unreasonable place to leave it. And you do get some info based on obviously distal to the edge in terms of whether it's diffuse disease or negatively modeled, just based on how the artery looks. The gastromesia talk about like a double stripe IVUS sign that I don't pretend to understand too well, but people are trying to at least, get a little bit of a sense of what the imaging can tell us based on whether it's disease or remodeled, and then how to maybe think about taking stents from a sizing standpoint. But I don't know, Bill, what do you think? I mean, whenever I get aggressive on the ends there, I always wish I didn't. So I tend to be a little more measured. I'll take the hit on not perfect expansion to not have to put, a 12 millimeter on the edge I just dissed.
I think with the DAP world that we're in, I think you can accept a little bit of distal haziness, or if you're going to look at it on IVUS, like in the section. But I agree with everything you just said 100%. And I think Bill Lombardi had told me a long time ago that he will size it to the distal vessel. He'll leave a strut or two that he knows, like if he came back years later, that's going to be underexpanded, but he'll accept that and fit the rest of it to the size of the vessel that he's predicted upstream. So, but I think we've overkilled this case, and Katie probably has something good to show, and I don't want to ruin her time. So Pratik, why don't you defer to her and let her show her case?
Yeah, perfect.
Perfectly fine. Yeah, let me share my screen here.
Pratik, as we're bringing the slides up, did you have your surgeon see that guy, or is it just a conversation? I don't want cabbage, you had at it.
Sorry, say that again.
For that patient, did you have your surgeon see him, or was it a simple conversation? I don't want my chest cracked open.
No, it was a simple conversation. I mean, the guy was fairly, active, and he was, he knew what he wanted. I mean, he understood.
Yeah.
So he actually, he's like, I read up a bunch of articles and know there's new technology and techniques. So I want to, see if my vessel can be opened back up.
Great.
Sorry, I tried to be technologically savvy today and use 2 screens, but I'm clearly not capable of doing that. So 1 second. Okay, does that look good?
Great.
Great, perfect. So the first case I have, I think Pratik and I were gonna kind of go back and forth, is a case that I did with Jamie McCabe last year, basically using imaging and physiology to guide PCI in a woman with pretty bad renal dysfunction. So she was is a 56-year-old female who came to a nearby hospital with an NSTEMI, kind of classically presented with chest pain. Her high sensitivity troponin at the outside hospital was 167. Her creatinine was elevated from her baseline, which was already abnormal at 3 compared to 2.5. She had an echocardiogram, which showed an EF of 45 to 50%. She had no prior imaging available to say whether this had been a chronic finding in her, and some basal inferior hypokinesis. She had a number of medical problems, the most notable of which were her CKD, some polysubstance abuse, tobacco use, which led to COPD and hepatitis C, as well as diabetes. So she underwent coronary angiography. I will say up front that her left main was pretty short, so the images are a little challenging, but this is what we had when we got called about her. She has an RCA CTO. She clearly has some disease in the proximal vessels on the left side, which I think are better appreciated, but still not laid out perfectly when they swapped out for a guide. Sorry, I don't know. I think you can clearly see that she's got some proximal circ disease that appears calcified, and it kind of extends a little bit into this tortuous vessel. And then her proximal LED has some calcium, though is not laid out in any pictures very well, which is why I left these two as the representative images, because these were honestly the best that we had. But she was still having chest pain, and so was transferred to the University of Washington because the small hospital that she was at didn't really feel that they were capable of managing this. I'm well aware that the pictures don't lay things out very well, but if anyone has any initial thoughts on the findings.
This is life in CTO PCI.
Yeah, exactly.
Pictures where the question is, can I open it? And
Yeah.
I don't know. I can't see it, but
Yeah. Yes, I would say I find that more often than not, we get pictures that we wish were a little bit more elucidating. So she was actually seen by a cardiac surgeon at the other hospital that she was at, because it was a satellite hospital for a bigger system. And they had already kind of preemptively turned her down for CABG due to primarily her substance abuse and lung disease, in addition to her CKD. So she was transferred to the University of Washington with the assumption that she was going to undergo PCI. But for academic purposes, I was curious how people would score her from a syntax standpoint with the limited images that you have available, because I kind of plugged her into the syntax calculator a number of ways. If you are generous and say that maybe it's just a proximal circ and a proximal LED that's calcified in her RCA CTO, you could get her syntax score as low as 25. But if you considered it as a left main, because the left main is short and maybe that calcium that's in the LED extends back, you could get it as high as 34 or so. I don't know how other people approach this when you just don't have great images and may not be able to get better ones in the setting of pretty significant renal dysfunction.
I think, Stefan, there's nobody, like, you're the head of CTO ARC, and there's nobody better to comment on that than you.
I can go back to them.
You know, I think it's a there's more than the CTO here. It's the complexity and it goes beyond the discussion of CTOs and everything, right? It's a high syntax score with a clear reference to a high volume center where, you know, I think the outcomes with experienced operator like they have at UW might not be the same as what was observed into the syntax study. And I would say that this has to be taken into consideration with what we know of the syntax score, the syntax trial, the stents that were used, the ability of the operator to do complete revascularization and everything. So I don't know if actually the data we're looking at the predicted outcomes is actually would be reproduced exactly as it is. I think surgery has not changed that much since syntax. And actually, I have to say that in syntax, surgery was quite good. And in Europe, there was a high use of bilateral IMAs. So if add syntax would be repeated here in the US, where there's a you know, where the SVG is certainly the most common vein graft used, and stents have changed substantially. I don't know if this mortality on the long run would be the same as it was discussed and exposed. So, but it's difficult. You're there as the operator. You get this patient referred for PCI, and seems that the discussion has been aligned in that direction. And Katie, what was this patient's perspective was? Expectation was to get a PCI, not surgery, right?
Yeah, her expectation coming from the other hospital was that she wasn't a candidate for surgery, and that she would be getting PCI. I also her
and also, you know, the syntax score at the predicted outcomes is in patient for which they would have done surgery. So when you get a surgical turn down, there are other factors that are not captured into the syntax score itself, right? Because otherwise this patient would have been operated. So you get into, and a lot of study shows that the predicted adverse events is maybe varies from 3 to 7 times the risk of PCI complication versus if you're not surgically turned down. But we don't know what it would have been, the outcome. You don't have studies where you have someone who says, first surgeon says no, and the second surgeon says yes. That would be a first turn down. This is a bit like our world of PCI. You have one says, I'm not doing it, but I'm sending it to someone else, and then you do it. But that's a very, I would say that in that case, it's a high syntax score. It's going to be a difficult case. But if you have the mandate, I always say to the fellows, get a mandate that's clear. Don't get the mandate yourself. Like it's always better to have someone sending you the case with a clear mandate than taking it by yourself and convincing the patient into your idea or whatever. It makes everything better. And in your case, you have the freedom to offer the best you can do to that patient, especially if she's already turned down, and that no matter what your local surgeon will be saying, that's pretty much the expectation they had from the referring hospital, right?
Yeah, and I think that sometimes something that we talk about not infrequently is in someone who mostly has proximal disease, if she had early in-stent restenosis or seemed to be somebody who didn't respond well to stents, she still has distal targets down the road. She's quite young. There was a lot of concern regarding the social dynamics of her case and her ability to recover from a big surgery versus something that would be easier to recover from PCI.
Mm-hmm.
So I think in that sense, we thought that we could get her a good result with fairly minimal contrast using imaging and physiology guidance to try to preserve her renal function and get her out of the hospital.
Kevin, question: how would you assess physiology in a tortuous circ? With wiring that potentially straightening.
Yeah, it doesn't work if you pleat. So you need to be really clear. If deplete the artery, you get false abnormalities, and that's a place where a nice, well done, non-invasive PET stress can be favorable to tortuosity. So it's one of the places where wire, especially a stiff one, is not going to work at all. And so being mindful of that.
I appreciate your PET stress thing.
What'd you say?
That's laughable. I mean, you can't assess it invasively, and I think we've all learned you cannot assess anything non-invasively.
There's been a couple cases where extreme tortuosity, not IFRable. There's at least been a conversation. Our PET team is really good. They do these sort of fancy, high-end attenuation corrected PETs. That is, they send me patients for cath. They're more often right. I mean, a MIBI is a bimodal test, and whether it should even be ordered at all is a question, which I know you have strong feelings about, Bill. But Pratik asked a good question. I mean, as unreliable as the angiogram can be, a stiff pressure wire is going to be equally unreliable here, just because you can't tell if it pleats sometimes. It can give you a
I
pseudo
agree.
lesion.
There's no way there's no way you're gonna assess this vessel like non-invasive.
Yeah,
Like,
for what it's
You
worth,
just got to
we-
go with the fact it's 90% stenosis and it's going to get fixed. I
Gonna have
agree.
Yeah.
to rely on you at some point.
we made no plans on doing physiology of the circ. We felt pretty confident angiographically that that needed to be fixed. It was more the where and to stent the LED and whether or not it involved the left main that was kind of our discussion regarding whether to add a physiology piece to it. So we actually elected to treat the left main circ system and leave the RCA for a different day, given her baseline AKI on top of CKD, and the fact that that would be a much more challenging intervention, at least based on our available images. I don't know if other people would have done that differently. I will take silence as a, everybody would have
Yeah,
done
I
what we
think
did.
pretty much, right. I think the whole thing here is the whole, it's the circumflex, right? You really want to target how much you're gonna do in this case, right? And the circ is doesn't seem to be much of a difficult call in terms of significance in there. So you already, so here you're basically what you wanted to know is how far down in this LED you needed to do anything. And I think physiology in the LED is less likely to be, have pitfalls from tortuosity and anything. And on top of it, I think that there's not much of a need to interrogate the circumflex. So I think it's I agree with the strategy. Although IVUS could have been also just as good, right? Because you're gonna need IVUS anyway for that procedure also.
We did physiology of the LED, which did actually require us to have a workhorse down it to even get the pressure wire X, which we have, to go down. So I think there's a reasonable argument to be made that that could have affected things, though we did normalize the physiology wire with the workhorse already in. But distally, it was quite abnormal at 0.67, but there was a clear step up right kind of where you see the calcium and disease angiographically that went up to 0.9. So we kind of marked that as our interventional point. We had a brief discussion about whether or not to proceed directly with atherectomy, and initially intended to put the IVUS catheter down to better help us determine whether or not that was needed, but the IVUS catheter wouldn't pass. And so that really ultimately kind of made our decision for us. And we did atherectomy with a 1.5 millimeter burr. This case was from almost a year ago. So
You've got a crazy bend after the lesion. So how are you going to atherectomy this? I'm Katie or Kevin. Like, are you going to like short it and try to stay away from that curve, or how are you going to do that?
I'm not going to use orbital. It's a little tough by Zoom. I can't see how much calcium's there, but it looks like I'd always be a little happier if I could get, if the roto starts to decel and doesn't want to make that turn, I probably wouldn't push it. It's a little bit of a, when you got your hands on it, how's it going type decision, Bill. What do you think? I mean, roto should behave okay around that. So
Yeah,
did you step up after that?
It has to be a controlled like activity. Like, I mean, you cannot just run it down. I mean, you got to just work on what you got to work on. But I mean, orbital to me would be really worrisome.
Yeah, and the main portion seemed to be kind of in the flatter segment, though we did end up engaging some calcium kind of around that bend that you'll see on the one IVUS run that I have here, that we kind of came around that a bit.
A couple practical tips. The burrs will often decelerate in calcified beds like that. You just got to be mindful to really pack slowly and not push them, because when they push them, they wrap, and that's when they dissect and bad stuff happens. So there is a little bit of technique. It'll go. You just need to have a bit of patience. And so you get a sense of how it's going. I've had some cases like that where the bird doesn't want to go through, and then you need to do some other things, which we talked about. But effectively, my sense is looking at that, the roto would probably pass as long as you take your time and do it in a relatively measured and deliberate way.
Yeah, which was our experience with this one. The only IVUS I saved, or roto run I saved, of course, was kind of near the last one where he had already done some work that you can see we kind of popped through perhaps a little bit more than we intended around that bend near the end there. But otherwise it went just fine, and we post-dilated with a 3.0 NC. We also performed atherectomy of the circ with the same 1.5 burr, though I didn't save any images of that. We're constantly in our lab commenting on how we're always forgetting to fluoro save our roto runs.
The circ was what I was asking about.
Oh. Let me go back to so from the circ standpoint, we basically rotated into, we avoided that curly Q in the more distal vessel, and really just rotated kind of right before the upsloping segment. So didn't engage that 360-degree loop at all.
Yeah, you don't need to. It's pretty normal. There's nothing good that's going to come out of driving around that circle for no reason. I agree.
Yes, I think that would have made me very anxious.
How about you, Bill? Those types of pigtails are the ones where bad stuff happens. And
yeah, I want no part of that.
Yeah, driving.
I was talking about the
We agreed.
Exactly. So, but it's nice. You get a little, as Katie said, there's a nice little area to short it, just get it through and stop it before it starts you up. And,
exactly. Or IVL is the option there. So
yeah.
Did that straighten out at all, the circ with the wire?
Yeah, you can see this is our IVUS guided imaging to determine our stent placement, and with the wire in, it did straighten out a fair amount, and which she tolerated she tolerated just fine.
Yeah, and one thing, I mean, I'd be interested in, Stefan and Bill's thoughts. The fact that it straightens with a rotowire, some people say, oh, that's great. But to me, that means it's a little more likely to be pleated. You can't see it. When you drive a rotoburr through folded tissue, that's when bad stuff happens. And so I would look at that as not necessarily a reassuring thing. Potentially, it may even mean that you're going to get in more trouble with it. What do you think, Bill and Stefan?
Yeah, I agree. I agree with you. It's not necessarily a good sign, and that's one of the reasons why I'm not especially enthusiastic about rota extra support or any. I prefer a rota wire that conforms better to the vessel than something that's going to create a lot of bias and deep cuts. I agree with you. However, it may help delivering the burr. But again, I think, as you pointed out, the technique is absolutely crucial here. You just don't want to push too hard and trap. And I think one way to avoid rota entrapment is never to use a 125 burr. If you want to have a rotoburr entrapment, use a 125 without having used anything else, and then you're almost guaranteed to have some entrapment. So I would have done.
Stefan, Pratik, why not? Why does a 125 burr entrap? Or anybody?
Pratik, you know the answer.
It has to do with the where the actual drilling, in the shape of the actual burr, it's less football shaped than the larger size burrs. Essentially, it's more, more an oval, right? then yeah.
Yeah, Stefan and Bill, I can't remember the last time I used a Roto XS except in a wire across gear wouldn't go scenario where I free wired with it, because it does free wire a little better. But I think every other case where I'm able to do microcath exchange, I use a Roto floppy. Is there any place, other than maybe trying to harness wire bias for nodules and some really niche stuff? I mean, I don't use it much. Do you guys have any other thoughts on that?
It's funny. I asked Jeff Moses and John Douglas that same question, which is like incredibly valuable to have these people like. So they use it at osteo lesions, and pretty much short of that. And we had the exact case today, and we didn't have a rotofloppy because we used them all week, and we had a hard back turn of a circumflex, and I won't use it. I use a rotofloppy like almost 100% of the time, but it's a rare time that I've run a roto stiff or a regular. I mean, Stefan, what do you think?
Yeah, I agree. I don't recall the time I used a roto extra support. I think it's roto floppy. Most of the time it does the work. And again, you're worried about too much biases and into your RE. And also, I think it's one key technique when you're doing rota, especially when you have tortuous vessel, is to try to move your wire and avoid burring on the same segment of the wire constantly, especially if you have difficulty to cross, because then if you move the wire a bit more distal, a bit more proximal, then you're avoiding the risk of cutting the wire actually. So especially if you see a wire, your burr making a curve, this is the situation where the edge of your burr may cut the wire. So it's very important.
We have since, this is our IVUS on a volcano system. We have since gotten HD IVUS, so my future presentations will be a little bit prettier from an IVUS standpoint. But for today, we have our non-HD IVUS images, which still had a lot of calcium distally in the circ despite initial atherectomy.
But the beauty
Did you get
with
the
this
eagle eye
IVUS,
around
Yeah.
there, Katie?
Yes. What's that?
Did you get the eagle eye around that bend? I'd be amazed. That's pretty
Oh
good.
no, we stopped we had no intention of stenting into that curve, period. I mean, I feel like we both felt, or at least I'm sure Jamie felt.
The beauty of this IVUS is that if you're able to get it through the lesion, you're ready to stent.
Yes. Perfect.
That's why I asked.
Yeah. No, we had I mean, I didn't even put it down there. We stopped where the vessel looked okay and recognize that we're not going to be visualizing that roller coaster that was in his circumflex.
I really look forward to know how much you manage this bifurcation afterward.
Yeah, we should. Yeah,
let's move on. So we want to see how you did that.
So same thing in the LED, which was obviously much easier to image and had a reasonable landing zone by IVUS. The vessels were fairly similar in size. As you can see, kind of coming back as the IVUS plays, the most significant lesion in the LED was really kind of at the ostium coming back into the left main right here. And then the left main itself is very short. There's not a lot to it. So the circumflex was around a 4.0 distally and kind of a 4.55 proximally, and then back into the left main where the vessel was quite large. And the LED was similarly kind of a 4.5 in the distal reference vessel, and then back into the left main was larger. So I think reasonable people would disagree as to how to approach this bifurcation. We elected to culotte it. I think Jamie had felt he could get a better result with that approach, given how short the left main was, but I think certainly reasonable people would perhaps have done a DK crush here, which was something that we talked about. How would other people approach it? Or how, rather, I guess my real question is, how do you approach short left main bifurcations? Is probably a better one.
It's a question where you're likely to get a lot of different answers. I don't think there's one way to do things. We just have to understand what's the limitation of each techniques, what not to do when you're using one of the other techniques. And if you're doing a culotte, you're doing right. If you're doing a tap, you have to do it right. But there's, there's principle to respect with every single 2 stent strategies or 1 stent strategy. But I think the data so far is not very strong in one when you need 2 stent strategy, like one strategy being stronger than the other one. There's only one trial with the DK crush. But again, I really suspect that in that trial, they were messing up their tap technique, because there's no way you can explain over 4% stent thrombosis in left main in the tap technique if by any other reason than maybe leaving too much stent in the branch hanging into the left main, or and that's the other thing that I've looked into the paper and I've asked a couple of questions. If you repot after doing a tap technique, you may turn into an internal crush. And I don't know what they did, because they were operators biased and wanted to prove that DK crush was the best. And obviously, if you're doing it and you repot after a tap technique, you may turn the whole thing into a disaster, because you've created a neochoroida. And if you go back and then you repot, you may have issues. So all these techniques, I think they work fine, but you have to understand what not to do and how to make it beautiful. I'm 100% sure that this culotte was done, nicely and well open. So it's as good as anything as a 2 stent strategy. That's what I perceive about 2 stent strategies. I don't know what, Kevin, you think about it. What is there anything you strongly favor? Do you think we have enough data on DK crush to say that this is the technique that should prevail, especially in left main, or is there still a bit more of a room for art and more than science? Let's put it this way.
I think there's room for more science, certainly. And to your point, there's inklings that maybe DK does better, but how those trials were done is important. I tend to take a way more utilitarian approach. If I'm worried about losing side branch access, I don't use culotte because DK keeps it. If there's a mismatch in branch sizing, then culotte's hard to do. And if I'm going to do a culotte, the place where I worry about culotte is in the openings to the pant legs, because doing a lot of imaging of them, it's pretty tough to get those to be perfect sizing by Kang criteria, or preferably bigger in Caucasians. And that was the case that Pratik has that he won't have time to show, where we culotte the left main. We were really attentive to knowing that those pant leg holes are really where the money is in terms of victory. And so I echo Stefan's point, know all of them, understand the pluses and minuses, and don't be dogmatic because one paper says that DK may be a little bit better. If you understand when to apply each and the pluses and minuses, I think there's a role for all of them.
Yeah, and we have to think about, culotte, DK, tap technique, T technique, all these strategies, they don't work by intention to treat. You got to do it the right way. And when you're looking at a big trial and outcomes and everything, it is very difficult and to generalize. And I think like the big message should be, if you're using 2 stent strategy or even 1 stent strategy, IVUS is a must in every of these cases, and you got to make sure that at the end you're satisfied, because if you leave a bad angiographic result, that's predictor of a bad outcome, I would say. So, and especially IVUS results. So I think I agree that culotte is a bit more of a tedious technique, because you gotta you sometimes have to recross within the branch, and then the branch is dissected and this and that. But again, I mean, if you're skilled like Bill with wires, I don't fear he's gonna unzip this LED down when recrossing the struts and going back into his LED. But things are to be considered if you've had extensive dissection into the branch. And I would say that before you conclude on your strategy, before you decide on your strategy, you need to assess after you properly dilated and done all the work. It's like sometimes how many times I had a strategy in mind, and then after the debulking, the rota, the everything, the IVUS and the ballooning, then all of a sudden strategy changes. And then you have to be sort of flexible throughout your preparation to be ready to assess what's going to be my final strategy. And it's difficult to plan it up front. That's my experience. I don't know, Kevin and Bill, do you actually have, like, are you starting on a bifurcation left main, having in mind clearly what type of stenting you're gonna do, or do you, in your experience, change a bit what you're gonna do?
Yeah, a lot of times it's, let's take in some balloons, stretch things, see how they open up, and then image and then plan a strategy based on that, because it evolves. I mean, the Mike Tyson quote is everybody's a plan to get punched in the mouth. I mean, looking at the vessels, whether they expand, whether they're responding well to ballooning, whether you're going to have to bail it in the atherectomy, are all things that end up being an assessment during the case. And I think when we get in trouble, it's like, I'm going to DK this, and then you find out that's maybe not the right thing to do. And so being fluid is certainly a good strategy in all of these types of cases.
In the interest of time, I will.
Hey, one thing that's important is, 3528 synergy in a relatively big main there in the bottom left. If you read left to right, then the next thing you did is you really cranked on it with a balloon. So you didn't have longitudinal foreshortening. And so using that particular stent in this particular scenario with a big guide, that step is critical, because we've all had the case where some stent you placed gets mushed by your guide, and it's an exercise in misery. So that's just a nice little teaching point you have outlined in your slide, which is something which is worth highlighting.
Yeah, and we had picked the smaller size because kind of more distally into the circumflex where there was a lot of calcium, the vessel was clearly smaller, and being thoughtful about making sure that particularly in the left main segment, things were as expanded as possible.
But the point is, do it earlier in the
yeah.
case versus later, because when it's hanging there and it's circumferentially malposed, it's at risk for being smashed by the guide or balloons. And so pinning it to the wall early before you start trying to do all your recrossing stuff can be helpful.
Then we put, after we jailbroke the LED, we did do kind of an initial kissing, and then put a 4048 in the LED, posted with a 4.5, and then did a final kiss with, or a kiss with 235 NCs. We did, speaking to everyone's point, how important intravascular is even afterwards to make sure that your stents are well opposed at the bifurcation. We did go back in and looked at the circumflex in particular, because we knew that we had undersized, particularly in the proximal circumflex. And you can see that coming up here. It's clearly underexpanded for that proximal circumflex segment. So hit that again with a 4.5 and then a 5.0 NC just at the ostium of the left main. And I think got a nice result. Only ended up using basically 10 cc's of contrast for the entire case. And she discharged home a couple days later.
Beautiful.
One of the things, Katie, which I would just have as part of discussion if I was planning this particular case with our fellow with the desire to use very little contrast, is there may be some value with tortuosity to a puff after you do the atherectomy run, just to make sure things are okay. So the places where it's smart to use contrast versus not, I think you're part of this. Jamie and I were in a live case the last day of TCT, I think 3 or 4 years ago, where a very highly skilled operator tried to do a low or no contrast roto case, and the burr stalled, and there is a dissection in perf that wasn't recognized because the whole point of the live case was to do low contrast. And so there's some points in the case where if, being low contrast mind is important, but a little judicious 3 cc's here and there at critical moments can be valuable just to make sure that you're not missing something. So
Yes, point well taken, certainly.
nice work though. That turned out really well, especially considering the challenges.
Really nice result. Yeah.
Awesome. Well, I think this brings
Yeah.
us to the end of our 90 minutes. Pratik and Katie, thank you very much for the time in to prepare these cases. And Stefan and Bill, as always, your expert commentary are also awesome. It's been really nice to catch up with our community and our fellows in this forum. So thanks to Bill and Kate Kearney and Jamie for putting this together and giving us a venue for this. We're excited by it. And we're trying to come up with some ways where we might get our CHIP fellows that are currently in training this year together in a single place. And I'll keep working on that and give you updates as long as we can get some funding for it and COVID doesn't derail it. So pleasure to be on with anybody. Any final thoughts, Stefan and Bill, Pratik or Katie? Thanks again, guys. Great job presenting.
Kevin, it's a really great job for you presenting and hosting. It's a lot of work. Nobody gives you credit, but thank you.
Oh, this is always fun to interact with you guys. I learn something every time, so I'm happy to be here. Thanks, Bill.
Yeah, it was great. It was great. Great case. Always a lot of learning points. And I enjoy these learning through cases because despite 20 years doing that job, we still learn every day. And that's what everybody should take as a message, is that there's no better way to do it from learning from others than learning from your own mistakes.
Well, through Katie and Pratik, thanks for the effort to put it together.
Yeah,
Wonderful.
good job.
Absolutely. Thank you. Thanks.
Thank you very much.
Great. Thank you.
Be well, everyone. We'll see you in a month. I'll have a good night. Take care.
Good night.
Bye-bye, everybody. Bye-bye.